ATCM, the emergency medicine channel. Today we will discuss regarding an acute coronary syndrome case discussion. We have Professor Dhanasekaran sir, Riaz and Vivek, myself Dr. Sri Krishnan. Can we start the discussion, Riaz?
Okay, sir. Sir, an old age man was brought to ER. He was brought from the ward, ER observation ward, where he was initially admitted with hypoosmolar hyponatremia, and in a ward he has developed some amount of dizziness with some chest discomfort, and following which he was immediately shifted to the ER. And in my initial 10-second assessment, patient was conscious oriented and was able to completely reply to my commands, sir. And went to the primary survey. Primary, I did a parallel survey. In airway appears patent, no oral secretions, no tongue fall, neck movements were within normal limit. Breathing, air entry was bilaterally equal, but bilateral minimal krebs were there, and saturation was 90% in room air. Since there is a fall in saturation, I started him on 1 liter nasal bronx O2, and then respiratory rate was slightly high, around 26 per minute, and then went to the circulation part. Circulation BP was 110/70 millimeters of mercury, and pulse rate was slightly tachycardia was there, around 101 beats per minute was there. And so after that, disability GCS was 15/15, and pupils were 2.5 mm bilaterally reacted. GRBS was only 146 milligram per deciliter, and exposure peripheries were warm. And I reassessed the primary survey. Now he is maintaining the air circulation, breathing, everything appears patent, and maintaining a saturation of 94% with 1 liter nasal bronx O2, sir. And as adjunct to the primary survey, I asked for an X-ray chest and also asked for an ECG and an ABG, sir. And in the adjuncts, ABG was showing a normal acid-base balance with a normal pH, sir, and lactate was slightly high of 2.6. And ECG was showing an ST elevation, and ST elevation was mainly present in the 2-3 AVF lead, sir. Inferior wall ST elevation was there, and so as soon as an ST elevation MI was diagnosed in this patient, since it's in 2-3 AVF, and immediately as an adjoint asked for a right-sided ECG also to rule out and right ventricular MI also.
Can you just explain regarding the ECG findings in the inferior wall MI? So what will be the inferior wall MI?
In inferior wall MI, there will be a ST elevation in lead 2-3 AVF. Okay. So in limb leads, there should even a 1 mm elevation can be taken as significant as ST elevation, while in chest leads only we require 2 mm elevations. In this patient, there was more than 3 mm of ST elevation, inferior wall 2-3 AVF, but in inferior wall MI, sometimes the right ventricular infarction can be ruled out by taking either the right-sided ECG, or we can say that the ST elevation will be more in the lead 3 compared to lead 2, and also there will be ST elevation in the lead V1, sir.
Okay. So ideally, if it is just an inferior wall MI, we should not have an ST segment elevation in V1.
Yes,
so whenever you take a normal ECG, when you see an inferior wall MI with a V1 ST elevation, we will think of probably there is an RV infarction. At that time, you will order for a right-sided ECG. After taking right-sided ECG, how will you confirm?
If the right-sided infarction is also there, there will be elevation in the V4, V3 range that leads, sir. V4, V5.
So ST elevation in V4R is conclusive of an RV infarction. And other thing that you can get in a normal ECG when you take is lead 3 more than lead 2. The ST segment will be more in lead 3 more than lead 2. So these are all the signs that will be given a conclusion. Anything else, bradycardia will give you any clue?
Yes, sir. Because SI node is mainly supplied by the right coronary artery. Okay. So if the patient is going into bradycardia, there is highly chance that patient's right coronary is involved. Okay. Right side infarction is possible.
In an inferior wall MI, what you want to remember is that approximately 30% of the patient presenting with an inferior wall MI can have an RV infarction.
Yes, sir.
So what is this knowledge very important? What is the management difference from a normal MI and an RV infarction? We are seeing an RV infarction.
Sir, one thing is that when usually the patient presenting with an acute MI, usually they used to have severe pain, and sometimes may be associated with the hypertension also. So probably at that time we may give morphine or a nitrate. But in a case of RV infection, we should not reduce the preload because patient can go into severe cardiogenic shock. So when giving, so in RV infection is suspected, it is better to avoid drugs like sorbitol, nitroglycerin, everything, and also giving morphine, sir.
Okay.
So this should be avoided.
What will be the management difference when the patient develops hypotension?
In hypertension also we have to give fluids in the case of RV infection, sir. So we have to maintain the preload.
So can we just go to the airway management, sir? Can we?
So what is the age of the patient you told?
This is an 80-year-old male.
80-year-old. Okay, he was being brought from the ward.
Actually, he was admitted today on that day only in view of severe hyponatremia, and in ward actually he developed some breathing difficulty, some agitation, following which he was immediately shifted to our ER.
Any other comorbidities?
Actually, he is a known case of already diagnosed case of SIADH and recurrent UTI episodes are there. And he's taking he's a CAD. His history was there is a history of coronary artery disease, but we don't have the exact details, and he's not on any antiplatelet, but he's taking digoxin, sir.
Okay. Any renal?
No, sir, no renal impairment, no metabolic issues, sir.
Okay. No. Suppose this patient is going for respiratory dysfunction, how will you diagnose and how will you manage? How will you proceed with?
One thing is that if the patient is developing desaturation, or patient is going into severe respiratory tachypnea, or patient is falling in sensorium wise, then we may have to go ahead with the definitive airway, sir. At that time, we should initially start, since it is an ST elevation MI, we should parallelly inform the cardiology and do the load him with the aspirin and load him with aspirin. And if we are planning for a PTCA, then we should load him with the Brilliant also. Or if we are planning with the thrombolysis, we only have to be clopidogrel, sir, and statin should be loaded. Parallelly, we should intubate this patient to secure the airway. At that time, already we should have secured an IV line, and we should be using drugs like for analgesics, you can use fentanyl. Fentanyl can be safely used, and 0.1 microgram per kg, 1 microgram per kg fentanyl can be used. Then ethomidate 0.3 mg per kg, it can be safely used. It is cardiovascularly stable. One thing to be remembered is that we should better to avoid ketamine, sir, because ketamine causes a tachycardia as well as an increase in heart rate. So the myocardial oxygen demand will increase, sir. So in CAD and the patient in ongoing suspected myocardial infarction, ketamine should be avoided. And drugs or muscle relaxant, both preferring is it's a non-depolarizing muscle relaxant like rocuronium or vecuronium can be used, but preferred for RSI will be rocuronium at a dose of 0.9 mg per kg. And we can secure the airway, and selecting the FiO2 will be we have to attain a saturation, maintain a saturation above 92%, sir. That's all. And it's better to avoid start on high FiO2 initially to avoid free radical injury.
So the main thing you have to keep in mind is no further hypotension.
Yes, sir.
So all your drug selection should be going in line with that.
Yes,
whatever drug which will be causing alteration in the hemodynamics, especially hypotension,
yes,
we have to avoid. And number two, so why are you avoiding morphine?
Morphine, because in case of RV infection possibility, there will be sudden decrease in preload to the patient, so it should be avoided, sir.
Okay. So there are two reasons. One is respiratory depression may be worsened, or the histamine release and peripheral vasodilatation, which may cause further hypotension and prolonged action.
Yes, sir.
So these are all things. If at all you want to use, you can use a combination in a very smaller dosage, but the pain relief is also a important aspect you have to keep in mind, especially. It itself may be increasing the heart rate. Okay, good. So whatever agent you are using, ethomidate is a good choice, and regarding the muscle relaxant, we can go for the rocuronium.
Okay.
So these are all the things. And pain relief, we can able to continue with either fentanyl or a combination of fentanyl and morphine in smaller doses. Once the stabilization of hemodynamic occurs, we can proceed. And as you told, the oxygenation part should be judiciously taken care. So hyperoxygenation we have to avoid. As you told, the free radical formation will hamper the situation.
So now in the initial itself, we have diagnosed as it's an ST elevation MI, and we have ruled out an RV. There is no RV infarction in this patient. I immediately loaded him with the 325 milligram of aspirin, and actually we already I gave him clopidogrel 300 milligrams, sir, and atorvastatin 80 mg was given, but the patient was not complaining of any pain at that time, so analgesics was avoided at that time. and along with that his BP was continuously monitored and there was no hypotension initially, and I immediately informed the cardiology to take the patient for cath lab and do the PTCA. But at that time he is not, even though not a CKD, his ABG which I initially ordered was showing the creatinine also, but the creatinine was abnormally elevated, sir. For this patient it was more than 4.5. So, so the PTCA was actually deferred because of that, even though it is not a relative contraindication, but with in considering the age of this patient and in view of raised creatinine, the PTCA was deferred. So immediately we planned this patient with going ahead with the thrombolysis of this patient.
Just for the audience sake, normal ABG won't give you a creatinine. Whatever the apparatus what we have in our department will give an additional creatinine. So normal ABG, the standard ABG will not be showing. So that's what we just wanted to for the audience sake. So the ABG you got a creatinine of high, it was around 4.5. So we decided to go ahead with thrombolysis
of that patient.
Okay. So next one, before thrombolysis, let me quickly ask a few questions. What will you do when this patient develops hypotension?
So in this patient, hypotension is that first we have, if the patient is fluid or deficient, then we can give bolus of fluid if the hypotension, sir. Even after fluid resuscitation, if the patient is not maintaining a MAP more than 65, then we can stop ionotropes, sir. If the patient is associated with bradycardia, we can use a dopamine, or if the patient is not having already have adequate heart rate, then preferred agent will be noradrenaline, sir.
So again, there is a lot of dilemma in using noradrenaline as a first line agent.
Yes, sir.
But there are a lot of studies that have shown that noradrenaline is superior to dopamine.
Yes, sir.
As you know, the dopamine, what is the problem with dopamine?
Dopamine is that dopamine has an increase in heart rate also. For the patient who is already in an MI, increase in heart rate will cause an increased myocardial oxygen demand. So compared to noradrenaline, there is no increase in heart rate. It has more of peripheral vascular constriction action. It helps in increasing the BP without increasing it, causing a tachycardia. Yeah. So noradrenaline will be preferred compared to dopamine. But when the patient is already having a bradycardia and if we want to increase the heart rate to maintain a MAP,
maybe dopamine will be a preferred
agent, sir.
As you know, dopamine is a dose dependent. You will have 5 microgram, you will have a less than 5 microgram just action on the renal artery. More than 5 you will have majority of the alpha, and more than 10 you will have the beta action. So alpha and beta action maybe from around 10 microgram you will start to get. So that is a problem with dopamine. So as you see that many of the maybe the practicing cardiologists will not prefer noradrenaline, stating that it might cause coronary vasospasm. But that is just theoretical. You can safely use noradrenaline and a combination of maybe dopamine if needed. There is a bradycardia.
Yes, sir.
So that will be the ideal agent. First line agent will be noradrenaline and followed by dopamine if needed. There are any other contraindication. Okay, so you started on noradrenaline. So what is basically noradrenaline helps? How does it help?
One is that one causes peripheral vasoconstriction.
It is basically an alpha action. It's a peripheral vasoconstriction. So how will you improve the inotropy?
By first one is by increasing the preload. Okay. By increasing the preload, again the contractility increases because of increased force. Increased distension causes increased force of contraction due to Starlink's law. Another action is that with a proper heart rate, it will be giving good output, sir. Severe tachycardia will actually reduces the heart rate. Other than that,
for example, this patient is having a blood pressure of somewhere around 70/40.
Yes, sir.
Just for the sake of discussion. So 70/40, we started noradrenaline. And now the BP is over 100/60. You wanted to add any other agent, or you are just happy with noradrenaline?
We can actually add dobutamine at this moment, sir. Dobutamine actually has good increases the force of contraction. And dobutamine, but one thing I have to make sure is that systolic BP should be at least 90, because if we are starting dobutamine at low systolic BP less than 90, possibility of his action on peripheral vasodilation will be more, and the patient can go into severe hypotension.
So it should be always remembered that dobutamine you wanted to start, make sure that the systolic BP is above 90. Or maybe you can use a combination of noradrenaline with dopamine. You start noradrenaline, then increase your systolic BP, then you add a dobutamine or any other inotropic agents like levosimendan. But levosimendan advantage is that there is no problem with your hypotension. Even if much earlier to noradrenaline, you can start levosimendan. But in an ER setup, it is little bit difficult to start this of inotropic agent. Maybe we are not very used to starting a levosimendan or a milrinone infusion. So what we prefer will be a noradrenaline followed by a dopamine. Maybe later on we can think about a calcium sensitizer like levosimendan. Okay, you can continue. So this patient was quite stable otherwise. So you decided to go ahead with an thrombolysis. As the family was not agreeing for a primary, as well as considering his age and other risk factors like renal failure, we decided to go ahead with an thrombolysis. Okay, fine.
So going with before thrombolysis, I immediately went with the ample history to make sure there is no relative contraindication for this patient.
Can you please say a few definitive contraindications?
Sir, there are definitive contraindication is that a patient should not have any intracranial vascular abnormality, no intracranial neoplasm, no intracranial bleed history should not be there, and other things that you should not have any bleeding diathesis, nothing should be there, and a known case of any aneurysm should not be there, and no use of streptokinase in past 6 months is a absolute contraindication. Allergic to streptokinase is also absolute contraindication, and
you have other agents like tenecteplase, TP and all, but streptokinase was the first drug that we started using as a thrombolytic agent. Okay.
These are some of the absolute contraindications. Okay. Compared to relative contraindication is one is pregnancy, uncontrolled hypertension, and surgeries or recent CVS within the past 3 months. These are some of the relative contraindications.
Is menstruation a contraindication?
Menstruation as such is not a contraindication.
It's a physiological it's not a contraindication for thrombolysis. That's one thing that you can remember. So you have decided to go ahead with thrombolysis. So which agent you have decided?
For this patient we actually go ahead with a tenecteplase. Okay. Tenecteplase actually it's a dose depending upon the weight of this patient. Actually we gave a tenecteplase of 30 mg for this patient, and it is a one single dose bolus dose tenecteplase can be given. Okay. Other drugs which are available is that one is alteplase. Alteplase if you are using means then we have to give 15 mg IV bolus followed by 0.75 mg per kg infusion for the next 30 minutes followed by 0.5 mg per kg infusion for next 1 hour. That will be use of alteplase. Then if you are using retiplase means then we have to give 10 units IV bolus. After 30 minutes another 10 units IV bolus should be given. Okay. And another one is most common use is streptokinase. That is 1.5 lakh international unit should be given over 1 hour in 50 ml 5% dextrose. Okay. But possibilities of allergic reactions are very common.
So it is less than 1% only. So there has been the advantage of streptokinase is the cost effectiveness. Maybe for just 2,500 rupees you can get streptokinase, which one the other one will cost you in lakhs. Yes. So that will be the difference, major difference. And the other problem with streptokinase and advantage of tenecteplase and retiplase is the flow. What is the flow that you are going to achieve post thrombolysis? So can you just
ideal flow is that we have the TIMI flow grading, sir. Actually, if TIMI flow 1 means that there is no revascularization attained. TIMI flow 2 means that the clot has been bursted, but distal to the clot is still not perfused. TIMI flow 3 means that the entire artery is getting perfused, but the cells may not be getting adequately perfused. TIMI flow 4 means that exactly in a normal comes back to normal scenario with best perfusion. So all these comparisons are based on achieving a TIMI flow 3 grading system. For compared to that, alteplase and this tenecteplase have good TIMI flow 3
as compared to streptokinase. They can the PCA will be the best choice.
PCA is always the
best choice. But whenever there is a contraindication or we are not able to go ahead with the PCA, always thrombolysis is a preferred agent. Can you just say the indication for thrombolysis? Just so imagine that you are in a center where you don't have a PCA facility or where you can't refer the patient for the next 2 hours, he can't reach a PCA center.
I would like to briefly say in AHA, we are following AHA guidelines, sir. So any patient who is coming with an ST elevation MI, then the goal will be within door to balloon time allowed is 90 minutes for any patients. That is that always we prefer PTCA for any patient. But if there is a delay, primary coronary intervention. If there is any delay, like if we are taking more, if we will require more than 2 hours for the patient to go ahead with the PTCA, then it is the indication for going with the thrombolysis. And thing is that if we are not able, if we cannot even transfer the patient to a nearby center with the PCA within the next 2 hours also, we can initiate the patient on a antifibrinolytic agent, sir. Okay. That's the major, that's the actual indication for going with the thrombolysis. Clinical indication is that patient is deteriorating, patient is going into hemodynamic instability, and the patient
Instability, PCI will always prefer. Whenever the patient is going for more of hemodynamic instability, PCI is the preferred choice. But when you don't have anything else, you can go ahead with thrombolysis. What will be the ECG criteria? Okay, this ECG finding, I will go ahead with thrombolysis. Okay, this is not an ideal candidate for thrombolysis. How will you decide?
ECG criteria as such, one should the patient have a proper ST elevation and that
two conditions should have.
Even at least in 2 continuous leads. If it is chest leads, minimum of 2 mm elevation should be there, and limb needs there should be at least 1 mm elevation with the reciprocal changes, sir.
Okay. Or a new onset
LBBB should be taken as an MI, sir.
Or the next indication will be a true posterior wall
MI. Posterior wall MI. In posterior wall MI, there will be shown as anterior leads, there will be ST depression, for which we can do an extended ECG with the lead V7, V8, V9, in which reverse the ECG and we can
reverse the ECG and confirm a true posterior. So there will be the definite indication, and where you will not thrombolyze. Okay. This ECG finding is not for thrombolysis. Which ECG findings?
One is J point elevation. Elevation can be
just
there.
A J point elevation, or maybe an ST segment depression. Rather than the true posterior wall MI, if we are just seeing an ST segment depression, we are seeing more in favor of a non-ST segment elevation MI, where we will not prefer thrombolysis, or the ECG is not meeting the criteria. The ST elevation criteria is not meeting. So those candidates we will not thrombolysis. So we will be briefly. What will be the time frame? Till what time frame you can thrombolysis?
Ideally, it is up to 12 hours, sir. Patient's onset of symptoms up to 12 hours. That's ideal.
As soon as possible, it is the best. But if the patient is coming a delayed presentation,
even after 12 hours, the patient is coming, patient is having ongoing chest pain or symptoms, then patient should be taken for PCI, primary spontaneous intervention.
So you decided to thrombolyze this patient. During thrombolysis, what are things that you will monitor?
One thing is that during thrombolysis, we have to monitor the ECG. Before thrombolysis itself, if the patient is having very low GCS, we should preferably intubate and secure an Ryle's tube, and also catheterize the patient also. During thrombolysis, what we have to monitor is, we have to monitor the ECG for revascularization changes. Usually, it will be an accelerated idioventricular rhythm, and that's
or we can call it as slow VT.
Slow VT. Another thing is that if the patient, while doing thrombolysis, going into VF or VT, then we should know that the patient is not getting revascularized and patient is going into further myocardial infarction.
So this patient, for example, luckily this patient never had any of this complication. We can just presume for the sake of discussion, you have started thrombolizing. Okay. So at the time of thrombolysis, suddenly the patient went into a ventricular tachycardia. So how will you manage this ventricular tachycardia?
If the patient goes into VT or VF, irrespective of patient is getting thrombolysis or not, we have to again start as ACLS protocolally, sir. If the patient has gone into VT or VF, then we will have to shock this patient. And since it's a shockable rhythm, we will have to DC shock the patient and try to revert. And immediately we should start the CPR also.
Okay. So any drugs, for example, this patient is thrombolyzed and post thrombolysis is developed, you don't have any other symptoms, but just the patient is having a ventricular tachycardia. Maybe you can call it as a stable ventricular tachycardia. So any other drugs that you can think of? Lignocaine, that is standard practices, we will think of always of amiodarone, but lignocaine is also a better option in a case of an ACS related ventricular tachycardia. Maybe in AHA guidelines it has not been emphasized much, but previously it was definitely a very good practice to consider lignocaine whenever the patient is developing any of this wide complex tachycardias, especially post myocardial infarction. Okay. So reperfusion arrhythmias, you need to remember, reperfusion arrhythmia is actually, like as you said, accelerated idioventricular rhythm. Maybe the heart rate will be somewhere around to 120, somewhere around 120, and it will be a wide complex rhythm. Otherwise, we can call it as a slow ventricular tachycardia. It's actually a good sign of a reperfusion. So when you see a slow VT, that is actually a good sign of reperfusion. But if the VT is not stopping there and it is going into much from an accelerated idioventricular rhythm, it is going to a VT or VF, that is not a good sign. Okay. Can you continue what you have done to the patient?
So this patient, after taking the consent, we go ahead with the thrombolysis of the patient, and within the next 45 minutes, actually, he didn't develop any revascularization changes for the ECG for this patient, but his symptoms started subsiding, and his repeat ECG, the ST elevation was coming down, and we actually started him on heparin also. Heparin was started for this patient, and he was admitted in CCU, and only complication he developed was within next 4 or 5 years he actually went into hypotension, and he was actually started on noradrenaline for that patient. And he was actively, after controlling his creatinine and his CKD, his AK has been resolved. He was planned for an elective CAG to see for any occlusion required.
What are the other drugs that you need to start within 24 to 48 hours?
Things to be started is, one is aspirin has to be started,
that will definitely have started
antiplatelets. Other than that, statins, and we can start heparin. And for cardiac remodeling, we can start AC inhibitors.
For ventricular remodeling, you have to start AC inhibitors, ARB or spironolactone. So these are the 3 drugs. Maybe later on a beta blocker also to decrease the heart rate. So this will be the major drugs. Sir, any other things?
See, what are the ventilatory strategies you will adopt to this type of cardiac problem?
What we have, since this patient has a possibility of going into hypotension, then one thing we have to keep is that maintain a low PEEP ventilation, sir.
Very good.
Because it will increase the intrathoracic pressure and the venous return can further get reduced. And maintain a proper PEEP and maintain a proper tidal volume.
Other still than need that, to give PEEP or no need for PEEP? Totally avoid, or you want
we should not completely avoid, sir. Maintain a normal PEEP is fine. It will cause lung collapse, sir. Lung collapse, and it will cause further hypertension.
There will be atelectasis in the basal regions.
Yes, sir.
So we have to keep minimum 5 centimeters.
5 centimeters.
Don't exceed. Yes, this may cause further hypotension.
Other than that, we will have to change the ABG according to the ABG. If he develops, since he has developed an acute kidney injury, possibly of going into metabolic acidosis will be there, then we will have to change the ventilator strategy according to that, sir.
Avoid hypo or hypercarbia and hypoxia, and tachycardia as well as hypotension. These are the basic things you have to keep in mind. No undue respiratory rate increase which may produce hypocarbia or too low causing hypercarbia. These are also should be avoided.
Can you just brief regarding what are the events for the conclusion?
An 8-year-old man was brought to ER with acute onset of chest discomfort and breathing difficulty, and initial 10-second assessment is having an only desaturation, and further evaluation he found that his patient is having an ST elevation MI, that too in the inferior wall, and we proceeded the patient with going ahead with the PTCA, but because of COMOPS and bystanders lack of consent, we proceeded with the thrombolysis. The drug of choice selected were tenecteplase, and tenecteplase 30 mg was IV bolus was given, followed by the patient he symptomatically improved, and his ST elevation started coming down, and his chest pain also coming down, and only post thrombolysis complication that he developed was hypotension, which was managed with an ionotropes, and right now patient is in CCU waiting for CAG, hemodynamically stable, sir.
So after the thrombolysis, what was the ECG finding?
Actually, this patient only ECG finding that the Q wave started gradually forming and ST elevation segments were coming down, sir, in the inferior wall.
So is that a good sign or a bad sign?
Actually, it's a good sign for this patient, sir.
Q wave maybe it will disappear after some time. But the ST segment has come down itself more than 50%. If the ST segment has come down after thrombolysis, that itself is a good sign,
sir.
This cardiac problem in similar type of patients, when you are maintaining the patient on ventilator for longer duration, the most important thing is you always see that adequately the patient is sedated with analgesia effect as well as muscle action. See, never allow the patient to fight over the tube or struggle over the tube, which will increase the heart rate as well as BP changes. So it will be increasing the work of myocardium and increase oxygen demand. So how will you tackle this one? You have to, well in advance, before the action is wearing off, you have to plan your schedule, or continuous infusion should be ongoing and periodic assessment should be happening.
So it was a good presentation, Riyaz. So what we have to give the take home message is that whenever we have no other option of doing a PCA, always PCA is the best option for a patient with ACS. But when you don't have any other option, always the previous method of thrombolysis still holds good. And whenever maybe in a scenario, whenever peripheral setup where we don't have any facilities for PCA, always you can go ahead with thrombolysis. Even streptokinase is an very old drug, maybe 1950s it has come up in the market, but still it holds good, and you can still thrombolyze the patient with a reasonable outcome.
Yes, sir.
Not with a just poor outcome, with a reasonable outcome if you are doing it on time. Maybe within less than 3 hours within the onset of time, maybe it is very good to go ahead. Less than 1 hour, excellent.
Okay.
So that will be the conclusion. Thank you
so much.